Hi all of you, I am going to do the recall session of the NESS last exam, and so that we will see what are the questions that were asked and framed, and the answers and explanation with reference will be given now. Okay, let's go ahead. So primary sclerosing cholangitis is not associated with which of the following? Option A, Riedl's, option B, retroperitoneal fibrosis, option C, Hashimoto's, and option D, ulcerative colitis. See, this question on the same day we discussed without reference and explanation. Today with reference and explanation we have, and whatever the answer that I gave you on that day, the answer holds the same. There is no change in the answers after the reference. Okay. So the right answer for this question is Hashimoto's. So Hashimoto's is a chronic lymphocytic thyroiditis, correct? Chronic lymphocytic thyroiditis. Hashimoto's can predispose for the risk of non-Hodgkin's lymphoma of thyroid. All these are associated with fibrosing conditions, Riedl's, retroperitoneal fibrosis, ulcerative colitis, directly connected to primary sclerosing cholangitis. The answer is Hashimoto's. The reference, and this is available as a reference for all three textbooks, and I have just taken from Schwartz 11th edition. Primary sclerosing cholangitis is an uncommon disease. Okay, is an uncommon disease characterized by inflammatory strictures involving the intrahepatic and extrahepatic biliary tree, and progressive disease, and eventually results in secondary biliary cirrhosis. And sometimes biliary strictures are clearly secondary to bile duct stones and acute cholangitis and previous biliary surgery or toxic agents, and termed secondary sclerosing cholangitis. And however, primary sclerosing cholangitis is a disease entity of its own and with no clear attributing cause. The autoimmune chronic low-grade bacterial viral infection, toxic reactions, and genetic factors suggestive or play a role in pathogenesis. Primary sclerosing cholangitis is associated with other autoimmune diseases including ulcerative colitis in 2/3 of patients, Riedl's thyroiditis, and retroperitoneal fibrosis. Are you able to understand what I am trying to tell you? So this is what the question that was asked in the exam. Okay? And the answer is very clear in NESS, general surgery questions. Okay. So NESS of May session. Endoscopic parathyroid surgery. Who did the first to perform? So videoscopic or endoscopic parathyroid surgery, and I told you on the same day of the exam, the discussion of the class. Yes, it is Gagner. It is Gagner. Yes, and you can see the endoscopic approaches include video-assisted total endoscopic technique. Total endoscopic parathyroidectomy was first described by Gagner in 1996, and several other investigators have since reported on this technique. And the very same question is also available in concept based in general surgery in parathyroid session. You can just go and refer back in Speed Learning app. While performing a laparoscopic cholecystectomy during creating a pneumoperitoneum, anesthetic informs about a sudden hypertension and a mill wheel murmur. What will you do next? What will you do next? So what was your answer? All of you? So the mill wheel is the key word here. Two things you should contemplate here. And the mill wheel is typically an auscultatory. It's an auscultatory finding, and it indicates the gas in the chambers of the heart. Okay. So mill wheel murmur, air embolism. It looks like a gas embolism, and you should put the patient on the left lateral decubitus with the head down. Okay. And you can aspirate the gas because once you do that, the air of the gas will float on the topmost on the chamber. Then you can put in a needle and you can aspirate the gas from the chambers of the heart. And I mean, you can have an echo, and an echo guided, you can do it. Okay. And if it is not mill wheel murmur, suppose this word is not there in the question, and it could be a compressive effect of the pneumoperitoneum, and in that situation you should go for reverse Trendelenburg. Okay. So you should have that in your mind. And there was a question asked previously, What is the most common cardiac rhythm abnormality in laparoscopy? The answer is bradycardia. So that was the previous year question in any one of the NESS exam, and this kind of questions have started appearing now as the complications of laparoscopic procedures. Okay, so the same explanation is available and you can go through it and it will be posted in the app. Mesenteric cyst falsus. Mesenteric cyst falsus. A, majority are cystic, majority are solid or mostly malignant, and benign and malignant with an equal frequency. Because this is what the question is able to collect, but the problem here is one of the option has to be out, because there are two answers here. There are two answers. So it can be used to know what was asked and also help us to learn the same could be asked in the future exam. So one is option B and the other is option D. Majority are cystic and benign and malignant are not equal. Malignancy is less than 3%. Okay. So there are two answers which are there for this question. Okay. Mesenteric cysts are a rare benign disorder with incidence of ranging from 1 in 27,000 and 1 in 2.5 lakh admissions. And the cysts are also caused by disruption of the lymphatics in the mesenteric, either by traumatic disruption or mechanical obstruction, congenital lymphatic malformation, and most of the cysts are unilocular, but also multilocular cysts or multiloculation also have been seen. They usually lined by a single layer of columnar epithelial cells. Presentation of mesenteric cyst is varied, with some being found incidentally on imaging exams and causing abdominal pain, and others are causing abdominal pain or symptomatic and cyst rupture or torsion. Chronic symptoms are usually non-specific, including abdominal pain and discomfort, anorexia, distension, nausea, vomiting, and changes in bowel habits. Symptoms are due to local compression of the abdominal structures. 45% of the cysts are found incidentally. Physical examination reveals abdominal mass in 60% of cases, and Tilloch's sign is an abdominal mass lesion that is only mobile laterally, and contrasting to the omental cyst, is usually freely mobile in all directions. That means it moves perpendicular to the line of attachment of the mesentery, and a band of resonance and fluid thrill. The classical triad. And CT scan and ultrasound can be used for diagnosis, and cystic lesions usually appear as a fluid-filled masses without solid components. See, that is the key word. Without solid components. It's sometimes being difficult to differentiate from mesenteric from the cystic masses from solid tumors based on imaging. Mesenteric cystic lymphangioma may present as a numerous cyst on imaging. Up to 3% of mesenteric cysts contain malignancy. It's not equal. So the question, it was not equal. In the option, there was an equal. No, it is not equal. Only it is most predominantly benign. Mostly as a sarcomatous lesion. One recently published series of 19% of patients harbored malignancy, and solid component within the cyst structure are associated with higher rates of malignancy. Okay, let's go back to the question and see. Okay, so majority of cystic is correct, majority of solid is not correct, and solid or mostly malignant, yes, it is correct, and benign and malignancy are not equal frequency. And medullary thyroid cancer falsus. RET mutation is most common mutation. Genetic testing is mandatory. Central compartment nodes involved in 50% of cases. Prophylactic thyroidectomy can be done based on serum calcitonin levels. Clear-cut answer here. All of you? Yes, please. See, the right answer is option D. Prophylactic thyroidectomy is based on the documentation of RET oncogene mutation. Understood? Very, very clear. So, rest of all the options are right, and central compartment nodes are involved, and this is also correct. Genetic testing is mandatory, is correct, and RET mutation is the most common, correct. See that? Most of MTC are sporadic, however, 75% within the spectrum of several inherited syndromes of familial MTC, MEN2A, MEN2B. All these variants are known to the result of secondary to germline mutation. There is RET oncogene mutation. The diagnosis of MTC is established by history, physical examination, raised serum calcitonin, CEA levels, and FNAC. Attention to the family history is important, because 25% of patients with MTC have family disease. So, you need to do a genetic testing as well. And because it is not possible to distinguish sporadic and familial disease at initial presentation. Okay, sporadic, yes, with the clinical examination, CA level and FNAC. But familial, you need to document a genetic study to document it could be a familial disease. And all new patients with MTC should be screened for red point mutation. So that's a genetic study has to happen. Pheochromocytoma and hyperparathyroidism. Central compartment nodes are frequently involved early in the disease process, so that bilateral prophylactic neck node dissection should be routinely performed. Prophylactic thyroidectomy, see that prophylactic thyroidectomy is indicated in red mutation carriers once the mutation is confirmed. Very, very, very important. Is it okay? If the option is option D, Prashali says, the option was lateral neck dissection. If it is going to be a lateral neck dissection, suppose it's going to be a lateral neck dissection, is it prophylactic? Is it a prophylactic? If it is a prophylactic lateral neck dissection, and again it is not based on serum calcitonin level, it should be, the index lesion should be more than 1 centimeter. Okay, so if that is that, this is the solution for it. Is it clear? Okay, perforated appendix is which type of wound? Clean, contaminated, dirty. Though it's a spillage and it has to be with a surgical history. So it is not there, so we will take it up into dirty. So perforated appendix, next exam it comes, and for the answer should be dirty. Let's go on. Next question. So you know about the clean. No inflammation is encountered, uninfected operative wounds. So there is clean, and clean contaminated respiratory, alimentary, genital or urinary tracts are encountered under control condition, like lap chole and those kind of surgeries. And contaminated and dirty we have discussed now. Transanal excision of rectal cancer, correct except. Involving more than 40% circumference, 7 cm from anal verge, size 2 cm, T1 with no nodes. So the right answer is involving more than 40% circumference is not correct. So the distal 10 cm of the rectum are accessible transanally. This is the key word, number 1. Because this question, the option carries, this lesion is 7 cm above the anal verge. For this reason, several local approaches have been proposed for treating the rectal neoplasms. Transanal excision is an excellent approach for the non-circumferential benign villous adenoma of the rectum. Transanal endoscopic microsurgery and transanal minimally invasive surgery make use of specially designed proctoscope and magnifying system and instruments similar to those used in laparoscopically to allow the local excision of the higher lesions higher in the rectum. Although this technique has been used to select a T1 and some T2 and carcinomas and local excision, does not allow pathological examination of lymph nodes and might therefore understage the patient. Moreover, local recurrence rate are higher after transanal excision and salvage surgery, while often curative, has been reported to be associated with poor survival than with initial radical surgery. And current recommendation is to limit local excision for T1 lesion. See that T1 lesion in patients of well to moderately differentiated and lesion size less than 3 centimeters. See the keywords here. Or in patients medically unfit for radical excision. In general, local excision of any rectal neoplasm should be considered an excisional biopsy because a final pathological examination of the specimen may reveal an invasive carcinoma that mandates for more radical therapy. Is it clear? So now we move on to the question. So 10 centimeter up to can be used. Maximum of 3 centimeter the cutoff, T1, all are correct. Okay. Incorrect about solitary rectal ulcer syndrome, SRUS. Correct. If you know for one option sure that is wrong, and definitely you can ignore rest of it. Because solitary rectal ulcer syndrome is common on anterior rectal wall. And solitary rectal polyp is more commonly seen in the posterior rectal wall. Okay, rest of the options we look, they are correct. Abdominal rectopexy is a treatment. Most common symptom is bleeding. And diagnosis is by colonoscopy with biopsy. Perfect. Straightforward question. I am not going into the details of the explanation here. Hyperbaric oxygen therapy is a factual question. Each session is 30 minutes. Results seen only after 15 to 20 sessions. And TCPO2 less than 35 millimeter indicates wound hypoxia. Middle ear trauma is the commonest complication. Excellent. It's a factual question. Each session lasts for 90 to 120 minutes. Hyperbaric oxygen treatment for hypoxic wounds are usually delivered 1.9 to 2.5 atoms. Substan 21st edition, page number 140. 90 to 120 minutes each, with the patient breathing 100% oxygen. The treatments are given once daily, 5 to 6 times per week, and should be given as an adjunct to the surgical and medical therapies. And clinical evidence of wound improvement should be noted with 15 to 20 treatments. Transcutaneous oxygen, oxygen pressure is used to access the wound perfusion oxygenation. And a wound and transcutaneous oxygen pressure less than 30 mm room air indicates hypoxia. See, same word to word. An in-chamber TCPO2 of 200 mm of mercury or more suggests the potential benefit of hyperbaric oxygen therapy. Complications of HPO therapy are caused by changes in atmospheric pressure and elevated PO2, middle ear barotrauma ranging from tympanic membrane hyperemia to eardrum perforation are the most common complication. See that? Very clearly given. Only 15 to 20 sessions you will see the results. The same substan, see how they are taken. Middle ear barotrauma is a common. See, everything is there. Each session 90 to 120 minutes. So that is the change. That's the reason why we make questions like that from the book. Because it will be the paragraph that is converted into the question. See that? 15 to same 15 to 20. Same numbers. There's a very idea of doing it. See? Eardrum perforation will be the most common complication. Okay. Cutoff value of CD4 count of renal transplant with an HIV patient. This is a simple, straightforward, repeat question. Everybody will answer correct. So you should not take a credit of answering this question and will not give any benefit in ranking. Okay. Answer is 400. So 628, 21st edition substan. Human immunodeficiency virus was once contraindication for transplantation. However, select patient with an appropriate cell count of CD4 above 400 cells per millimeter cube. Okay, and an undetectable viral load have good results with transplantation. As a treatment modality of HIV, associated nephropathy. Super. Excellent. Clear-cut question with a clear-cut factual number available for reference. Okay. Obesity surgery morbidity index includes all except DVT, gender, hypertension, type 2 diabetes mellitus. So the right answer is type 2 diabetes mellitus. So the risk factors include arterial hypertension, age more than 45, male gender, body mass index more than or equal to 50 kg per meter square, risk factor of pulmonary thromboembolism. So which does not fit into is type 2 diabetes mellitus. Okay. The risk of recurrence of diabetes mellitus after bariatric surgery involving biliary pancreatic diversion. Again, a very, very clear-cut question taken from the book. The numbers. The answer is, what is the right answer? The answer is 80%. See here, the diabetes remission, 3 years diabetes remission, sleeve gastrectomy, it is given in Bailey and Lau, 28th edition and 1185, page number. Sleeve gastrectomy, 3-year diabetic remission is 50%, gastric bypass 50%, and OABG 80%, gastric band 20%, BPD, duodenal switch, all 80%. So what was asked? So BPD was asked, answer is 80%. Very clear. Factual number as given in Bailey and Lau. As given in Bailey and Lau. Okay. Duodenal hematoma falcis. Presents after 24 to 48 hours of GOO. Commonly presents as perforation peritonitis. Okay. Conservative management with Ryle tube insertion. Rule out associated organ injury before observation. Okay, the right answer is, it does not present like commonly with perforation peritonitis. So let us go through some of the facts as given in Subsistent 21st edition. The approach for the management of duodenal injuries depends on the location of injury and the amount of tissue destruction. Hematomas of the duodenal wall will often resolve without intervention and issues only if causes gastric outlet obstruction. Treatment of obstructing hematomas consisting of gastric decompression, initiation of total parenteral nutrition, and re-evaluation of gastric emptying with a contrast study after 5 to 7 days. The duodenal obstruction persists after 14 days. Operative exploration is warranted to evacuate the hematoma. Evaluation of perforation, stricture, and associated pancreatic injury. Hematomas will frequently decompress spontaneously during mobilization of the duodenum. Intestinal wall should be evaluated for the injury. Duodenal hematomas are identified incidentally during laparotomy. Should not be intentionally opened unless there is a concern for full thickness injury. So it's very, very clear. Rest of the parameters are correct. Okay, it presents as GOO. That's correct. Conservative management, you need to put a tube across for feeding and rule out the associated organ injury, and also understand if it is causing complete obstruction, operative procedure is required. Okay, clear. Least common gene causing intestinal type of gastric cancer. What is the right answer? Option A, beta-catenin, option B, MSI, option C, APC, option D, E-cateterin. Right answer is E-cateterin. Correct. So E-cateterin comes under a diffuse type. See that? And intestinal type, subsistent 1-2-2-1, word to word. P53, APC, microsatellite instability. Just from the table they picked up. See that? In an order. In an order. And they made 3 from this and put 1 except for this from diffuse. So this is how exactly the questions were made. So I have given you all this. These are already available. See, all this are available in the app itself. There is a separate sessions for tables in Subsistent. You can just go through it. It is available in the app. All the material which are asked in this exam, or I mean, whatever the exam you're going to appear also, are much in very clear cut available as a resource material in the app. Okay, you can just explore and you can go through it. The flow rate of CO2 in 14 gauge varies net. This is the most common varies net that is used in laparoscopy. Understand that. So then what is the flow rate? Because you do this day and out or assist day and out. What should be your answer? Yes, please. All of you. Very closely related numbers. 20 liter per minute, 25, 30 and 35 liter per minute. Right answer is A, 20 liter per minute. CO2 gas insufficiency commences at low rate 1 to 4 liters per minute. Increase to maximum of pressure of 15 millimeter of mercury. The maximum flow rate of 20 liter per minute. The most common gauge needle used is 14. And that allows 20 liter per minute. Bailey and Love, page number 102. 20th edition of Bailey. Intraperitoneal colonic injury, all are true except. Option A, Hartmann can be done. Resection anastomosis and covering ileostomy. Primary anastomosis can be safely done. Primary anastomosis lead to more specific complications. This is an injury. This is not a pathology. There is a catch here. See, resection anastomosis and covering ileostomy was a traditional one. Now, this is little outdated. Now, I'll just take you through what is that given in the book. As per Subsistent 21st edition, the approach to operative repair depends on the presence or absence of destructive injury and overall physiology of the patient. Historically, the approach to all colonic injuries include resection and creation of a colostomy due to fear of anastomotic dehiscence in intra-abdominal sepsis. See that? So, resection and creation of colostomy. So, you don't anastomose. Correct? Subsequent experience questioned the need for mandatory proximal fecal diversion. This is what the question is asked here. And manage the colonic perforation. To manage the colonic perforation. Stone and Fabian first prospective described the primary repair of colonic injury versus colostomy creation in 1979, observing the lower incidence of intra-abdominal infection with the primary repair. See that? See the key, see the catch. Since that time, extensive investigation from Memphis conceptually Divergent management of chronic injury based upon the identification of destructive injury. What is the type of destructive injury? Destructive wounds in the face of a significant resuscitation. That is based on the resuscitation. How much of blood is required? That is not in the part of the question. More than 6 units of packed red blood cells and medical comorbid conditions were noted to the experience anastomotic leak of 42% versus 3% otherwise healthy and minimally transfused patient following following resection. That means this depends on the other factors like comorbid condition, how much of blood is required and all that. That is not in this question. So then we have to evolve an answer based out of what is given in the question. Thus, was developed a surgical stratification for an optimal outcomes of an operative colonic injury, recommending primary repair 1 or 2 layers in all non-destructive injuries, resection and anastomosis for destructive injuries in a healthy patient without extremis or diversion of a destructive injury in comorbid patients requiring resuscitation. The scheme holds true for both penetrating and blunt injury are not impacted by the degree of intra-abdominal contamination. Distal injuries require segmental resection with colonic anastomosis, colic anastomosis. So was this question correct? So based on, I hope you understand what we are trying to say. See, in summary, whatever might be the question, but in summary what I am trying to tell you is, do a primary anastomosis or resect and do a colostomy. These are the two things, correct? So one is primary, single stage, resection anastomosis, single stage. So primary, single stage of resection anastomosis, one stage, or resection and colostomy, and anastomosis later date. So this one and this one. See, this is for all less contaminated wounds or less destructive wounds. It's not contamination, less destructive wounds, and require less amount of transfusion, and like comorbid conditions, very minimal or nil. No diabetes, no hypertension, no CAD, or something like that. But here, this is for more than 5 to 6 pack RBC transfusion, yes, with more comorbidities that could predispose for dehiscence. Diabetes positive, COPD positive, hypertensive positive, CAD positive. So for this you take this procedure, and for this you take the procedure. Okay. So I think you should have that concept, and once based on that you will be able to answer whatever is being asked. If this is the question, this is the answer. But you need to have parameters in the question. That's what I'm trying to tell you. I don't know, is this a plain question like that, or something along with the comorbidities or type of injury has been as a descriptive way it was given in the exam. So based on that, you will alter the answer accordingly. Okay, FAP incorrectness. Again, there is a small, this is a controversial question actually. See, budesonide reduces the risk of inflammation and colitis. Thereby, the risk of transformation is hastened. Endometrial cancers are those cancers predominantly associated with HNPCC. Lynch syndrome. Do you understand what I say? You can think how steroid can reduce colon cancer. The use of budesonide, there are studies that are said how it has an impact. It cannot prevent. Try to understand. It is not a prophylaxis. It is not a prophylaxis. So don't take that away. But budesonide has a role. How it has a role? It reduces the inflammatory process in colitis. So, but is it associated with FAP is the question here. Again, there is a catch. How this can be associated? So, it's a vague question. I will not say it's 100%. D we can relate to something else, because I'll just show you a tabular column from Bayesian law 1357 where both are not there. Both option C and D are not here. So, endodermal derivatives of adenomas and carcinoma, particularly around the duodenal ampulla, also stomach and small intestine, thyroid, biliary, gastric, fundic or gland polyps, hepatoblastoma associated with the endodermal derivatives. Ectodermal derivatives associated with, these are manifestation of FAP. Ectodermal derivatives of epidermoid cyst, pilomatrixoma, congenital hypertrophic retinal pigment epithelium, brain tumors. And mesodermal derivatives, desmoid tumor, osteomas, there is nowhere that option D are directly related to it. But among this, I thought D could be the better answer than C. C can also be the answer, but compared to C and D, I think D could be an answer because it's predominantly associated with HNPCC. What do you say? Hello? Is this the way that was asked, or something else was there in the question? Huh? Same, okay. So, tricky one. Splenic artery aneurysm, when to intervene? Asymptomatic pregnancy, okay. Asymptomatic, aneurysm asymptomatic, okay, fine, understood. Image of a superior parathyroid gland or parathyroid gland are all true except dorsal to recurrent laryngeal each weighs to 40 to 50 milligrams and semi-transparent and neonate and derived from chief cells. The answer was, we discussed the same day, and the answer is very clear. It is not semi-transparent, it is yellowish, and it is very difficult to differentiate from the fat, and it is more, in adults, looks like yellowish brown. Okay. So, 21st edition of Subistan very clearly says, okay, normal parathyroid glands are oval, spherical and bean shaped, okay, and they vary colors from yellowish tan to reddish brown. With an average size of 5 into 3 into 2 mm in size and weighs about 35 to 40 milligram. The parenchymal cells of parathyroid gland consist of two principal cells, chief cells and oxyphilic cells. That's okay, but very close, na? Cells are clearly third cell type, which may occasionally be seen. Okay, fine. Most common enzyme deficiency in congenital adrenal hyperplasia. Very simple, straightforward question. The answer is 21, okay, dehydrogenase, okay, very clear. 21, hydroxylase deficiency. And virilization, adrenal insufficiency in children or pathognomonic of congenital adrenal hyperplasia, the autosomal recessive disorder characterized by a variety of enzymatic defects in the synthetic pathway of cortisol and other steroids from the cholesterol. The most frequent defect is 95% of 21 alpha hydroxylase deficiency. See that? 95%. There we go. CBD drainage contraindicated. Stone impact in the papilla, stone impact in the right hepatic duct. Okay. Mid CBD stone of 1.5 cm, the CBD of 8 mm dilated. 1.5 cm distal stone with the CBD of 2.5 cm dilated with the distal obstruction. Yeah, 21 alpha hydroxylase. So, what is the right answer? Stone impact in the right hepatic duct. Treatment of cholecystectomy, generally ERCP CBD exploration, which can be performed by laparoscopic open technique. Endoscopic sphincterectomy with the stone extraction, effective treatment for cholecystectomy. In the preoperative setting, it can clear the duct stones. When it is unsuccessful at the removal of all stones, it will appear as an intraoperative decision making. More than half of the patients managed with ERCP with cholecystectomy will have recurrent symptoms of biliary tract disease. Okay, large stones, usually more than 2.5 centimeter. Altered gastric or duodenal anatomy, such as Roux-en-Y, impacted stones, intrahepatic stones, we have intrahepatic stones, or multiple stones, are most common causes of failure of ERCP. So, intrahepatic, see what are the failure rates that could be seen. Okay. Impacted stones, intrahepatic stones, multiple stones, most common causes of failure. For a bilateral adrenal tumor, if the adrenal vein sampling of the left adrenal tumor is done, then how to go about it? So the right answer is femoral vein to IVC, IVC to left renal vein, left renal to left adrenal. Correct. The left adrenal vein is approximately 2 cm long and drains into the left renal vein after joining the inferior phrenic vein. The right adrenal vein is typically short and wide and drains directly into the vena cava. Okay. If it's going to be right, you can go straight from the vena cava to the right adrenal. You do not go through right renal vein and to adrenal. So that's the difference. Indication for staging laparoscopy in pancreatic cancer are all except. So the right answer for this is option A. I'll tell you why. Staging laparoscopy has been advocated for several authors to means for reduce the frequency of non-therapeutic laparotomy for patients with an unsuspected metastatic or locally advanced or unresectable disease identified at the time of surgery. For patients who appear to have a resectable disease on the imaging studies alone, laparoscopy identifies an additional unresectable disease in up to 30% of cases. Others have argued that with the current imaging used properly, the benefit of additional laparoscopy only rarely alters the surgical planning. Recently, there has been some consensus on a more selective use of laparoscopy for those at particularly high risk of occult disease, including, see this? Let's come to the point here, including large tumors more than 3 cm, significantly elevated CA99, and uncertain findings on CT or body or tail tumors. Okay. So, more than 3 cm, CA99 elevated, and tumor involving body and tail. Now, shall we go on to the question now? Indication for staging laparoscopy in pancreatic cancer all except anything more than 3 cm involving body and tail, increase CA99. Is it okay? Clearly taken from subsystem. Says or no? Page number 1555. Okay. High risk features of IPMN except. All are high risk features of IPMN except jaundice, main pancreatic duct diameter than more than 1 cm, lymphadenopathy, enhanced solid nodule. This is a clear cut table based question. You can't miss it, and this is available in the app itself. Lymphadenopathy. Excellent. See that? Page number 1549, 21st edition of Subistan. These three have been made into 3 options and except is made into lymphadenopathy. See that? This is a worrisome feature. This is a high risk feature. The very same question available in the learning app and table based Subistan. You just, after the class is over, you just go and see. Main duct more than 1 cm, enhancing mural nodule more than 5 mm and jaundice. See? Same question. No difference. This is a worrisome symptom. This is how the questions are asked. So the very idea of doing such session is to make you understand that how are they picking up the questions and where are they picking up the questions. Unstable patient with a trauma to complete transection of the body of the pancreas. Complete transection. What is the best? This we discussed, and this very same question is also available in discussion of pancreatic trauma. The right answer is whether we have to remove the spleen or not, just wait, we'll just go back to the algorithm and come back to the question again. So, presumed pancreatic injury, complete exposure of the pancreas, hypothermia, coagulation, acidosis, yes. Damage control, control the hemorrhage, external drainage of the pancreatic injury, temporary abdominal closure. No. Pancreatic ductal involvement. No. External drainage with closed suction system. If ductal injury is there, yes. Determine the location of injury. Yes, is it there in the pancreatic head and uncinate, right to the superior mesenteric vessels, or left to the superior mesenteric vessel involving the neck and the body. Okay. If it is that way, and the answer will be distal pancreatectomy and external drainage. And if it is going to be right of superior mesenteric vessels, external drainage and secure the distal feeding access, or combined pancreatic and duodenal approach, or destruction of pancreatic head, then you have to go for pancreatic duodenectomy. This is Whipple's. So this is Whipple's. So if nothing is mentioned about spleen, and you should not go ahead with the spleen preserving distal pancreatiectomy with answer. Is it okay? Whipples will be reserved for destructive injury of the head of the pancreas. Head of the pancreas. Head and neck. Head and uncinate process. I'm sorry. Head and uncinate process. D2 gastrectomy for proximal gastric cancer, which of the following is removed? What's your answer? I don't know what exactly the question was asked. So with the options which were given to me during recollection, I just made it. So if this were the question, what will be your answer? I don't know, one should not be there. One of the options should not be there. I don't know which option was not there. So the right answer is all of the above, because D2 will remove N1 and N2 level. So D2 will remove N1 and N2 level. So D2 gastrectomy. So removal of D1 is N1 nodes, removal of D2 is N2 nodes. So you can clearly identify suprapyloric, celiac, what were else given? Splenic, hepatic, splenic, artery or hilum. Okay, all these are clearly coming under N2 and hepatic N2. So invariably removed. Capsule endoscopy are used in all except stricture in colon, submucosal tumor, polyps, and iron identifier or untraceable GI bleeding. Yeah, because stricture is an obstruction, so capsule endoscopy, capsule may not come out. Rest of all to identify the mucosal pathology. Okay. So this capsule endoscopy is a transparent capsule attached with the light source and the camera and a transmitter, where it takes images and transmits to the external data collection, and thereby you'll be able to see the mucosal pathologies as it travels down to mouth 2 and get excreted via the anus. So small bowel capsule provides a good visualization from mouth to colon, page number 153 from Bailey and Love, and high diagnostic yields. Okay. You know how long it takes its journey to come out? You know that? It compares favorably with other techniques for localization of occult gastrointestinal bleeding and diagnosis of small bowel Crohn's. Use of capsule endoscopy is contraindicated in patients with the small bowel strictures, in which it may impact and resulting in acute obstruction and requiring retrieval at laparotomy or laparoscopy. See the word it is given. What to say? See? Say how they have picked up. Huh? How they have picked up. Orals also, you know, but still see how it is very clearly taken from Bailey and Love, from Subiston, Schwartz. Hugger's classification, cancer up to submucosa. Very clear, stage 4. Okay. Hugger classification, level 0, carcinoma limited to the mucosa or carcinoma in situ. Level 1, carcinoma involving the submucosa limited to the head of the polyp. Level 2, carcinoma involving level up to the neck, junction of head and stalk, carcinoma. Level 3, carcinoma invading any part of the stalk. Level 4, carcinoma involving the submucosa of the colonic wall. You need to know in the question whether it was the colonic wall or the polyp. Okay, at the level of polyp. Okay, head of polyp, submucosa head of polyp is level 1. Colonic wall submucosa will be level 4. That's what, that clarity was not in the question. I don't know what was asked. So based on that, you need to answer correctly. There's a spelling mistake. Be corrected. Okay. I think then the better answer should be taken as a colonic wall than as stage 4 or level 4. Okay. Liver transplant. Order of anastomosis asked. So we know that infrahepatic IVC, suprahepatic IVC, portal vein, hepatic artery, bile duct. This is a very famous repeat question and the material available. Okay. So whatever the answer that we have discussed on the same day of the exam, except for 1 or 2 questions, rest all remains the same. And you try to understand, this is almost close to 30 questions. So for general surgery, we have discussed for the current session of ENESS, which a question was asked. Okay. And I have taken most of the references, more than 95% of the references from the app book session itself. Yes, for the similar appearing questions. So I am very confident that the material that we have in our app in speed, more than sufficient enough to crack the general surgery part of any exam. Okay, so I have given you this reference with explanation because it took some time. All that is loaded already, previous NEET questions I already have loaded, and most of it I have discussed revision for ENESS before the exams of this ENESS exam, and you can go through that. Okay, is it clear? Are you all happy? Hello. Done? Okay, thank you. Thank you very much.